Hello, everyone. Welcome. Thank you for joining our December LAN event talking about hypertension. I'm Rebecca at HealthInsight. I'm a project manager here. And I've got a panel of great presenters here with us today. So we're just going to dive right in. It's the top of the hour. People may join as we go along, but that's okay. We're gonna get started anyway. We're going to talk about what's new in the discussion about hypertension. We've got Dr. Barry Stultz from the University of Utah Medical Center, who's going to be talking about the new guidelines that were just released last month. And then we've got Carrie and Jamie from clinics here in Salt Lake City, Utah, who have implemented some successful home blood pressure monitoring programs. And we really want you to hear what they've done and take some away from that. A little bit about the Zoom platform before we get started here to get you familiar. If you hover your mouse along the bottom of your screen, you should see a black toolbar similar to the one that's on the screen. On the far left are the mute and camera functions. So some of you have cameras turned on. If you don't want them to be turned on, you can click that start video button and it will turn your camera off for you. But right now, some of you have your cameras on, so heads up about that. And the mute function is there as well. To the left of center is a participant tab. You can click that to see who else is on the call with us today. You can raise your hand from there. You can also mute and control your video camera from that as well. To the right of center is chat. And in the chat, a box will appear. And you have the ability on the bottom to send it to everyone or to the host. When we really encourage you to change that function to everyone. As a matter of fact, I'd like you all to do that right now. Click on chat, change it to everyone, and type in your setting. Are you a physician office? Are you home health? Are you hospital? Give us a little bit of an idea of where you are from. And a little bit about HealthInsight. We're facilitating this call today. We're the Quality Innovation Network Quality Improvement Organization. We align with the CMS quality strategy and help with quality improvement work in the 4 states, Oregon, Nevada, Utah, and New Mexico. So like I said, we're going to cruise right through because we have so many great presentations today. I don't want to waste any time. The ACCA 2017 Hypertension Guidelines are going to be talked about by Dr. Barry Stultz from the University of Utah Medical Center. You will all be receiving these slides after the presentation so you can read everyone's full bios. But he is a general internist and has some special interest in the management of resistant hypertension. So we are thrilled to have him here with us today. With that, I turn it over to you, Dr. Stultz.
Thank you. Let's look at some of the selected and clinically relevant recommendations that have come from this guideline, which was just released 1 month ago here. This guideline first was commissioned by the National Heart, Lung, and Blood Institute in 2014, and it has been reviewed and accepted by 11 other medical societies, which you see listed here. Of note, about 3 days ago, the American Academy of Family Practice has decided not to accept these guidelines or the blood pressure levels that are suggested, which we'll discuss. The scope of this document is impressive. It's very comprehensive. It covers diagnosis, treatment, prevention, and a plan of care for patients with hypertension. It incorporates 47 subsections in 169 online pages, and it includes 106 evidence-based graded recommendations that are based not only on randomized clinical trials and meta-analyses of those trials, but also on observational studies and on expert opinion. The document is available free at the American College of Cardiology website that you see listed on this slide. Well, this slide shows you that the ranking system, both for the class and strength of the recommendation and the level of evidence. And on most of the slides, I have tried to incorporate what the class or strength of recommendation is and what the level of supporting information and research is. So to summarize, what's new in the ACCA 2017 Hypertension Guideline? It includes a new blood pressure classification scheme, new target blood pressure levels, new hypertension drug therapy recommendations that are according not only to the level of blood pressure in a patient, but also to that patient's 10-year level of cardiovascular risk, specifically their risk of a fatal or non-fatal myocardial infarction and stroke. It includes a recommendation for initial low-dose 2-drug therapy rather than single-drug therapy for most patients with hypertension. And finally, it has a recommendation to adjust drug therapy using both office blood pressure and home blood pressure. Let's look at each of these concepts in more detail, along with some of the supporting evidence for these recommendations. Well, this is the new ACCA 2017 classification of blood pressure, and it's compared to the JNC7 2003 guideline. Note that the ACC 2017 guideline also defines normal blood pressure as a pressure below 120 over 80 millimeters of mercury. However, a blood pressure of 120 to 129 over less than 80 is now defined as elevated blood pressure, and hypertension is now defined as a blood pressure 130 over 80 or higher rather than 140 over 90 or higher. And stage 1 hypertension is now defined as a blood pressure of 130 to 139 over 80 to 89, with stage 2 hypertension as a blood pressure 140 over 90 or higher. Well, why do we have a new classification of blood pressure? Several reasons. First, we've known for many years that from observational studies that there is a log linear progressive increase in cardiovascular risk as systolic blood pressure increases above 115 millimeters of mercury. Each 2 millimeter increase in systolic pressure above 115 increases the risk of stroke death by 10% and myocardial infarction death by 7%. As a result, an elevated systolic blood pressure, ACC/AHA definition of 120 to 129, increases the risk of a cardiovascular event between 10 to 50%. But more important, stage 1 hypertension with a blood pressure of 130 to 139 increases that cardiovascular risk by 50 to 100% compared to a normal blood pressure less than 120 over 80. 25% of the U.S. adult population has a systolic blood pressure between now occur in persons whose blood pressures are less than 140 over 90. And finally, as we'll see, recent meta-analyses indicate the benefit of drug therapy for lower blood pressure levels. As an example, this is a meta-analysis of 123 randomized trials that had more than 600,000 patients. And it showed similar relative risk reductions in major cardiovascular events of between 20 and 37%, independently of whether the initial baseline blood pressure was above 160, or it was 150 to 159, 140 to 149, even 100 to 139, or even below 130. These relative risk reductions were present in patients both with and without coronary heart disease, stroke, heart failure, diabetes, or chronic kidney disease. Another meta-analysis of 34 randomized trials with 138,000 patients found similar relative risk reductions in major cardiovascular events of 24 to 31%, looking at final achieved blood pressures. Whether those achieved blood pressures were 140 to 149 or compared to above 150, 130 to 139 compared to above 140, or less than 130 compared to above 130. Cardiovascular events continue to be reduced down to a systolic blood pressure of 122 millimeters of mercury and there are substantial absolute risk reductions in cardiovascular events. It does appear that lower is better. Well, what are some of the consequences of the new ACC-AHA blood pressure classification scheme? It increases the prevalence of hypertension, and it magnifies hypertension as a public health epidemic. Compared to the JNC-7 definitions of hypertension, the ACC-AHA classification increases the prevalence of hypertension from 32% to 46% of adult Americans. That is 72 million to 103 million American adults. And these new prevalence levels differ according to race and age, as you see listed on the slide. However, as we'll discuss a little bit later, this guideline suggests either new or intensified drug therapy for only 12 million more persons in the United States. Not a lot. Well, the new ACC-AHA guideline appropriately focuses on the essential need for accurate office blood pressure measurement to screen for hypertension, but not to diagnose hypertension. Of concern to me is no specific recommendation is made in this guideline to use automated office blood pressure measurement performed on patients who are completely isolated within the exam room. That is termed in the medical literature now as, quote, AOBP, end quote. But there are these two supportive statements. Automated oscillometric devices provide an opportunity to obtain repeated measurements without a provider present, thereby minimizing the potential for a white coat effect. And that's really the key thing that AOBP does. Second, there is a growing evidence base supporting the use of automated office blood pressure measurements performed with patients in complete isolation. Similar to other recent guidelines, the ACC-AHA guideline emphasizes that out-of-office blood pressure measurement with either 24-hour ambulatory blood pressure monitoring, considered the gold standard, or with home blood pressure monitoring, if 24-hour monitoring is not available, is necessary and mandatory to accurately diagnose hypertension and rule out white coat hypertension. But the new ACC-AHA guideline goes a step further than other guidelines. It also recommends that we strongly consider out-of-office blood pressure measurement to both detect and treat masked hypertension, where out-of-office blood pressure is consistently higher than office blood pressure in patients whose office systolic blood pressure is 120 to 129 millimeters of mercury, further increasing the need for accurate home blood pressure measurement. Well, this diagram summarizes the algorithm from the ACC-AHA for out-of-office blood pressure measurement, both to detect white coat hypertension on the left of the slide, but also to detect masked hypertension, particularly in patients at elevated cardiovascular risk on the right side of this slide. And I'll let you take a look at that at your leisure to get more detail from it. This slide, which I'll also allow you to take a look at later in more detail, shows the ACC-AHA recommended algorithm for considering out-of-office blood pressure measurement to detect white coat effect and masked uncontrolled hypertension in treated patients. The previous slide was for untreated patients. This one is for treated patients. Again, detecting masked hypertension, where the blood pressure is higher out of the clinic than in the clinic, is most useful in patients with clinical cardiovascular disease or patients who are at high cardiovascular risk. Well, another key recommendation in the ACC-AHA 2017 guideline is to base pharmacologic drug treatment decisions not only on a patient's blood pressure level, but also on their 10-year risk of cardiovascular disease fatal and non-fatal myocardial infarction and stroke. Randomized trials, as well as simulation studies, have suggested that this approach will prevent more cardiovascular events and be more cost-effective than basing decisions on blood pressure level alone. The guideline recommends use of the ACCA pooled cohort equation, which is available online at the website at the bottom of this slide, to calculate a patient's 10-year cardiovascular risk if they are a primary prevention patient under age 65 and they don't have cardiovascular disease, chronic kidney disease, or diabetes. Note that 10-year cardiovascular risk is already 10% or higher in 90% of patients age 65 and over, regardless of their risk factors, and in literally 100% of patients age 75 and over, and in all patients with clinical cardiovascular disease, chronic kidney disease, or diabetes. You do not need to calculate the 10-year risk in those patients. It's already high. Well, this next slide shows the ACCA blood pressure thresholds for initiating drug treatment and the blood pressure goals. Well, I thought it did, yes, this one does. This slide shows the thresholds for initiating drug treatment and the blood pressure goals for treated patients. As you see, patients with cardiovascular disease or a calculated 10-year cardiovascular risk of 10% or higher, or age 65 and over if they are ambulatory and community dwelling, or if they have diabetes or chronic kidney disease. All of those patient groups should receive drug therapy if blood pressure is 130/80 or higher, and they should be treated to a blood pressure lower than 130/80 millimeters of mercury. In contrast, patients with a 10-year cardiovascular risk less than 10%, or patients who have had a prior stroke, should be treated with drug therapy if blood pressure is 140/90 or higher. And again, those patients should be treated to a blood pressure less than 130/80. This slide summarizes the ACCA 2017 recommendation for both lifestyle and pharmacologic therapy. Note that patients on the left of the slide who have an elevated blood pressure, 120/129, less than 80, receive lifestyle therapy alone. Patients with stage 1 hypertension with a blood pressure of 130/139/80/89, if they have a 10-year cardiovascular risk less than 10%, receive only lifestyle medication therapy, no pharmacologic therapy for those patients. On the other hand, patients with stage 1 hypertension, 130/139/80/89, whose 10-year cardiovascular risk is 10% or higher, and all stage 2 patients with a blood pressure 140/90 or higher receive both lifestyle modification and drug therapy and are followed up every month until their blood pressure is controlled to below 130/80. Supporting data for these blood pressure thresholds and target blood pressure levels for patients with a blood pressure 140/90 or higher, but a 10-year cardiovascular risk less than 10%, are derived from the meta-analyses that are summarized and listed on this slide, including the new ACCA meta-analysis of randomized trials that indicates a 16% reduction in major cardiovascular events by lowering systolic pressure below 130 as compared to leaving it 130 or higher in patients with a less than 10% 10-year cardiovascular risk. Once white coat hypertension has been ruled out, the ACCA guideline recommends on the left side of the slide initial one-drug therapy for patients with a systolic blood pressure 130/139 and a 10-year cardiovascular risk of 10% or higher. They suggest a diuretic or a calcium channel blocker for African Americans and any of the 4 major drug classes for other patients. Note that beta blockers should be used only for patients with ischemic heart disease or heart failure and coexisting hypertension. In contrast, on the right side of the slide, initial low-dose 2-drug therapy at the very beginning is recommended for patients with a blood pressure 150/90 or higher, and initial low-dose 2-drug therapy may also be considered for patients whose baseline pressures are 140/149, provided that standing blood pressure is not low, that the patient is not very elderly or frail, and that there are not prior issues with either hypotension, low blood pressure, or multiple drug intolerances. And the last slide that we'll talk about here is why is the ACC/AHA now recommending initial low-dose 2-drug therapy rather than initial 1-drug therapy for most patients? Several reasons. First, more than 75% of hypertension patients need 2 drugs to lower their blood pressure below 140/90, let alone below 130/80. Second, the studies, both randomized trials and observational studies, show that initial low-dose 2-drug therapy is more effective, more efficient, and more tolerable than maximal doses of a single drug. You get greater blood pressure lowering at 6 weeks with initial low-dose 2-drug therapy. You get better hypertension control over the first 3 to 12 months of treatment. You reduce cardiovascular events in the first 6 months in patients at high cardiovascular risk, and in most patients after 1 to 2 years. In addition, because side effects are proportional to dose for most drugs, fewer side effects are present, which will improve patient adherence to therapy. In addition, initial low-dose 2-drug therapy results in fewer drug titrations and thereby fewer office visits. And if you can use single pill combinations for your patients, it reduces their number of copays.
Excellent. Thank you so much, Dr. Stoltz. Now we have time for about 5 to 10 minutes worth of questions if you've got them. So you can either type them into the chat, we'll read them out. You also do have the ability to unmute yourself and ask your question out loud, which you are more than welcome to do. So I'll pause while you think of some questions. I'm curious how many people have, really heard much about the guidelines yet, or at least heard them summarized, and what your reactions were. I'm sure there are some questions about this, and see how they shake out.
Well, while we're waiting for a question, let me point out that about 2 or 3 days ago, the American Academy of Family Practice said that they are not accepting these guidelines. They will continue to follow JNC 8 guidelines, where in persons age 60 and over, the blood pressure goal is below 150/90, not even below 140/90, simply below 150/90. They have not published a detailed list of reasons why they don't like these guidelines, but in their statement, they suggest that they don't believe these guidelines are fully evidence-based. So there will be controversy.
All right, a little time for the dust to settle. And maybe while we're waiting too for any questions to come in, our next presentations are going to be about home blood pressure monitoring and setting up those kind of programs. And, there's some guidance in these new guidelines about the use of that. And if there's any more you want to say in support
the new
of that.
guidelines find an incredibly strong role for home blood pressure monitoring, both in the initial diagnosis of hypertension, which requires out-of-office blood pressure measurement, and note that I said requires, but also for managing therapy both up and down. This is the way to go.
Great.
There are currently no chat questions.
Okay. Anybody want to unmute themselves and ask a question? I'll pause again for a few more seconds.
We do have one chat question. Do the guidelines document life changes?
Yes, the guidelines see a very important role for lifestyle modification. Note that for patients with elevated blood pressure, 120 to 129 over less than 80, vigorous lifestyle recommendations should be provided to every patient. For patients with a blood pressure of 130 to 139 over 80 to 89, who have a less than 10-year risk of a less than 10% 10-year risk of heart attack and stroke, those patients do not receive drug therapy. Those patients receive vigorous lifestyle modification, which is detailed in many pages in these guidelines. Lifestyle therapy, very important for all patients, but especially it's the only therapy for those patients in the two categories I just listed.
Good question. So do you anticipate, I mean, obviously this is going to have some impact at some point, I would imagine, on the quality measure reporting that everyone has to do.
Well, that is one concern that the American Academy of Family Practice appropriately brought up, is what is going to happen with the requirements. And that we don't have a grasp. I think the essence of the ACCA guidelines is that lower levels of blood pressure are killing Americans, and we aren't taking care of those levels of blood pressure.
So yes, in the new guidelines, kind of the younger population, there's probably going to be a little more focus on that, and like the question before, lifestyle changes and some of that.
Yeah, we know that there are 7 million Americans between the ages of 18 and 39 who have a blood pressure 140 over 90 or higher, let alone 130 over 80 or higher. And only about a third of those patients have their blood pressure controlled below 140 over 90, let alone below 130 over 80.
Any final questions before we move to the presentations about home blood pressure monitoring?
And there are none in chat.
Okay.
Well, my name is Catherine Luke, and it's my pleasure to introduce, and if I can get in camera here, hello. My pleasure to introduce our two speakers who will be talking about home blood pressure monitoring. Thank you, Dr. Stoltz, for that excellent presentation. One solution to getting those required measurements is home blood pressure monitoring programs. Our first presenter is Carrie Jernigan, Quality Manager at Ogden Clinic. Carrie is an RN with over 15 years of experience and currently oversees quality standards, best practices, and organizational goals across Ogden clinics. Our second presenter, Jamie Fitzgerald, is the nurse care coordinator for Exodus Clinics. Jamie is an RN as well. She moved to the US from Australia in 1999 and is passionate about patient outcomes. Both our presenters are leaders in their fields, and we're pleased to have them here to talk about their home blood pressure monitoring programs. Carrie?
Well, thank you. I appreciate the invitation from HealthInsight to present today. They were instrumental in the success of our project, as were both Weber Morgan Health Department and the Utah Department of Health. And so we want to recognize them for their efforts in the success of this project. A little bit about Ogden Clinic. We are a multi-specialty practice with over 130 providers. Our footprint spans 2 counties, 22 specialties, 16 locations, and 8 of those were participating family medicine locations in this project. So the why, when, who, and how. The obvious why is that blood pressure control correlates in prevention of stroke and cardiac events, and that was really our main focus, is wanting to impact the health of our patients. And we also recognize that multiple quality and payer programs include that blood pressure control measure. And so we wanted to affect our performance levels as well. We recognized, however, that we lacked a consistent protocol across the multiple locations as well as tools, and that there was a need for consistent staff education. So this all began back in January 2016 when we received some grant money to explore this controlling of blood pressure through having the patients monitor their home blood pressures. And we rolled it out at 2 pilot locations of our family medicine, at our family medicine clinics. And then there was a secondary phase 2 of this project that happened in July of 2016, and it extended to the 6 remaining family medicine locations in our group. So the target patient that we wanted to aimed at improving blood pressure were both the newly diagnosed hypertensive patients as well as previously diagnosed hypertensive patients who were remaining uncontrolled. And our process to make those changes were to incorporate patient education and blood pressure logs, as well as blood pressure monitors to be used as loaners for self-monitoring to determine if the patient was truly hypertensive versus white coat hypertension syndrome. So these are some of our resources. Our patient education booklet, it incorporated various different components to anywhere from prevention to what's considered high blood pressure. It identified when to call your provider, and also had a list of medications on the back so that they could use that as a resource as they traveled from clinic to clinic and amongst providers. As well, some blood pressure monitors that we used in each of the locations and used as loaners so that the patient could take those home and determine if they truly, when they came back, if they truly had an issue with some hypertension. We recognized that our biggest resource was our staff, and that there was a need for us to improve to educate them on correct technique, and we used the Measure Up, Pressure Down video to do that, as well as promoting the project. We needed to educate not only on the correct technique, but also on what the expectations were for the project. And we also felt it was important to have some staff accountability. So we assigned a project lead at each location, and they twice a month would join us on conference calls where we could discuss the successes and barriers that people were noticing amongst all locations, and be able to make adjustments on the fly based on those barriers. We also ran reports early on to identify the expected enrollment at each location based on previous hypertensive measurements. And then we also provided staff incentives through monthly drawings for those who were enrolling. And we had a project status poster at each of the sites that indicated the identified expected enrollment and their progress towards that number. So the change process that we identified was to identify the patient, educate the patient, evaluate the progress, and hopefully the patient at that point would graduate from our program. So we identified the patient at the point of care. These were, again, either newly diagnosed patients or previously diagnosed patients who were poorly controlled. And at that point, they would transfer to the RN, and the patient would be educated on blood pressure management and given the booklet with instructions on how to use the blood pressure monitor at home that was given as a loaner. We also gave, in the education, there were recommended blood pressure cuffs based on best practices and best recommendations in the industry. And so we provided that information to them, and then they were instructed to monitor their blood pressure for 1 week with the loaner cuff and return to the clinic for evaluation. At that time, then when they returned, then they would visit with the RN, and the RN would look over the log with them and determine if the provider needed to be notified and whether any other interventions needed to occur at that time. And depending on that, on the course of that visit, then they would also follow up at 1 month with the patient's provider, and again at 3 months with either the RN or the provider to determine whether or not they could graduate from the program because they had some stabilized blood pressure. So our phase 1 locations, these are the final results here. Our enrollment for the 2 pilot program locations, our total enrollment was 55 patients. You'll notice that there's a column for attrition, and this was based on the metrics that we determined to accommodate for those that were identified as being patients with white coat hypertension. And so you can see that there were a significant number who presented to the clinic with an elevated blood pressure that once they were evaluated for a week at home and returned with those blood pressure logs, that they were identified as having normal blood pressure once they returned for follow-up. So that left a total of 34 who warranted treatment or intervention. And of those 34, 17 patients demonstrated a blood pressure reading less than 140/90 at the follow-up appointment. 5 additional patients with the blood pressure reading still over 140/90 still demonstrated a lower blood pressure in comparison with the initial blood pressure at the time of enrollment. So that indicated a 64% of those patients who qualified for treatment that showed an improvement in the blood pressure readings at the follow-up appointments. That you'll also notice there are 2 columns there, the 2 columns to the right, those patients were still being monitored at the end of the actual program, and we're still in the 1-month and 3-month follow-up phase. So the remaining 6 locations, there was a total of 166 patients that were enrolled in the program. 99 of those were, again, identified with white coat hypertension. And of the remaining 67, 24 patients demonstrated a blood pressure reading less than 140/90 at a follow-up appointment, and 13 additional patients, although they had blood pressures over 140/90, they demonstrated lower blood pressure at the follow-up in comparison to the initial enrollment blood pressure. So an overall improvement of 55% in those patients who qualified for treatment had improved readings at follow-up appointments. The project barriers and successes that we noted, one of the barriers that we had were that there was very provider and staff engagement across all locations. And you may notice from the previous slide, I'll just go back. Oh, maybe, there we go. The third location, location 3, had quite an enrollment, but also quite a level of attrition. And so, you know, that was a location that was very plugged in from the top to the bottom. And they were very, very anxious to find those patients that did have some white coat, just determine whether they had white coat hypertension versus truly a diagnosis of hypertension. Also, there were some data limitations. We thought about the potential of being able to pull a list of patients who may have had more than one blood pressure that was elevated over 140/90. And our EMR did not have that ability to do that. It would identify those who had at least one blood pressure of 140/90, but it couldn't determine, the programming was such that it couldn't determine to narrow that down to those that had had 2 blood pressures of 140/90. So that was why our focus was at the point of care, and we felt that that was successful and really the place where the intervention needed to take place. Knowing that those other that the patients eventually would come in and again be identified at that time. I feel like our successes were patient engagement. Definitely the improvement in blood pressure rates indicated that on the previous slides. Also clinical staff skill improvement. An interesting note was that for one payer program, we did have a 9% improvement in controlled blood pressure within a 4-week period of rolling this out. And so that to us was a success, and I feel that it was more not a diagnosis, not finding those that needed to be diagnosed with hypertension, but correct techniques that were the staff were using to be able to determine whether or not this was truly a patient that needed to be evaluated a little further. And one of the successes we feel were the provider and staff engagement. And you'll notice that I listed that as a barrier as well, because at certain locations, this was also a success, while in others it was a barrier. As well, our project planning, implementation, and management, that's a success as well. The framework for this project is going to allow us to be able to push additional projects into our clinics and be successful at that. We are extremely happy that we were awarded the 2016 HealthInsight Innovation Award as a result of this project, and we recognize that success and celebrated that with our clinics. So beyond the initial project sustainability, we have continued our ongoing staff education. and we've incorporated that into our new hire process. So everyone is at the on the same playing field. They know exactly what the expectation is and understand how to identify those who present with an elevated blood pressure. Ogden Clinic now supplies each location with the blood pressure patient education booklets that were initially funded with the grant money, and the blood pressure monitors continue to be utilized at all family medicine locations. We've discontinued reporting at a location level and having those conference calls, but the project continues just individually at each clinic, and the results continue to be evaluated at an organization level with the NQFAT measure. So lessons learned, I would say the biggest lesson that we learned from this is to plan the project, not the process. We thought we had it figured out, that the process would be identify, educate, evaluate, and graduate. And it just didn't work to just make that statement and say that was gonna work. So we really had to take a step back between phase 1 and phase 2 and really roll out the project completely so that everyone knew what their role was in the success of the project in identifying those patients. And that's really where the project became successful, as well as when we had that accountability in place. Also, lessons learned was to involve key stakeholders in all phases of the project. We did this initially, and this proved to be beneficial because the boots on the ground are actually the ones that can poke the holes in the project and find the things that are going to go wrong with it before you've rolled it out and found that things went wrong. We did make adjustments along the way, and that was very successful. A couple of adjustments that we needed to make. We recognized early on that we did not have a Spanish version of our education, so that was adjusted. We also added ways to prevent blood pressure. So we felt that was important to incorporate, and that was an initial omission. We also added large blood pressure cuffs as part of the project. And then each of the locations found that it was difficult to maybe get that knowledge transferred from the MA in identifying those patients who had an elevated blood pressure that was in the room. Sometimes the provider would come in right afterwards, and they would just go on with the visit and not recognize that was something that was a factor, regardless of whether they were there for that purpose or for just a simple sinus infection. So we developed some magnets that we put on the outside of the doors, and that became our method of having the staff members identify to the provider that this was a patient that they needed to be aware that they had an elevated blood pressure. Also, a lesson learned was to maintaining the regular communication with those who were managing the project at each location. This really, this touch point every 2 weeks, and then we backed off to every month as the project rolled out, made it so that there was some accountability, and it allowed those that were participating at other locations to share what was working and what wasn't. And that really became a big part of that project. We also recognized the need to maintain forward motion midway through the project and finish strong. So we rolled it out strongly at the first, and then about midway through, we took the project back out to each of the locations at the staff meetings and re-promoted the project and recognized them for where the success that they had already achieved halfway through the project, and still promoted that project continually. And then, as always, it's important to recognize the efforts of the staff members who are effectively implementing the projects and making a difference in our patients' lives. And we really had some success at our locations with this project, and we appreciate the opportunity to participate in those projects. Thank you.
Excellent, thank you. And we do have some questions coming in, so we'll have Jamie go through her slides, and then we'll get to those questions. Everyone's curious about monitors, which I knew would be a big question. Everyone always is. So if you want to pass the keyboard to Jamie, she can advance her slides. Thank you, Carrie.
So I'm Jamie Fitzgerald. I currently work at Exodus Healthcare, which has 2 locations here in Salt Lake City, one in Magna and then one in West Valley. Our program is a little less refined, and we're still in the process of really refining that and getting it going, as I'm a part of multiple programs we have running in our clinic. So ours is ongoing, very baby steps, I guess I would say, in regards to Carrie. So It's just been nice even listening to Carrie in regards to what they're doing in their programs. So hopefully I have a little bit of helpful information for you in regards to this program that we've implemented. So moving. So improvement opportunities. When I came on staff, they never had a nurse on staff before, so my role was undefined at that point. And so when I stepped in, I kind of looked at opportunities that I could possibly engage in or get up and running when I first started at Exodus. The big thing was having a champion for this program, the need to see what our practice values were in regards to hypertension, and then recognizing the need for improvement. And then just looking at our current management of hypertension, we were part of the Million Hearts Incentive in 2014, which brought attention to current hypertension practices in our clinic. And then we also participated in the Million Hearts, and we received gold status.
Which, Jamie, I'll just jump in. This is Rebecca in Utah. This is something that the Utah Coalition does. So if you're in another state that you might be wondering what that is, that's something kind of specific to the coalition here in Utah.
And then our goal as a clinic now is to work towards platinum status, which again would just create that opportunity to really refine this program and our hypertension practices. Then consistency across the practice was something that we noticed straight away. We are a smaller practice. We have 80 staff members, and we currently have 16 providers between the two practices. So we really want to focus on MA practice, provider practices, and then the patient education portion of that and self-management. Quality management report is where I started when I first came on. Our quality management team is still also being refined, and again, we're still just moving along in regards to getting that really rolling well. So we're just a very small team. So this report here is just the most recent report that I pulled in regards. We're a part of the ACO here in Salt Lake City, and these are just our most current numbers that just show a hypertension control rate for 140/90 is satisfied. So those patients' blood pressure is below 140/90, and then you can see there's 55% of those patients that are uncontrolled, and that's with the 1,019 patients. Then for our 60 plus years, we had 717 patients, 58% of the control rate of the 150/90 satisfied, and then you can see there's 41% that are unsatisfied. So this is just a great picture to see that we can really improve our current practices and what we're doing. Change process. I think the first thing I recognized when I came on is just the stages of behavior to change. It takes much longer than I originally thought it would take to implement something that seems so small and straightforward. It's a lot more complicated, and so this was really big for me in the beginning, just to realize that process. Again, staffing champion is really important. You have that person that is just over it, and then my next goal would be to bring on an assistant down the road to help me with those calls as I work in different areas within that clinic. Monthly meetings regarding the clinic and just where we're heading, and making sure that we're on point and we're heading in the direction that we desire to go. And then continued development, which I said earlier on. Management of hypertension, the patients. So currently we do group meetings, and then we do one-on-one, which I do with patients for education. Then we pull quarterly EMR reports currently, and then from there we do patient calls to those patients whose blood pressures are over 140/90, and then 150/90 for our 60 plus patients. Ongoing training for our MAs and providers. We're currently using the JNC 8 guidelines. And then since I started this program, I put in some policy and procedures. So there wasn't anything in place in the beginning, so we really started from the ground up. So. Change process. Again, we are moving towards that Million Hearts Platinum status, which means this really has to be refined, what we're doing, and consistency across the board. We actually teach all of our staff about programs that we implement, from our billing to scheduling to front desk staff. So they're also aware they can pick up on those patients if anything should come up. The picture on the right hand there is a card that we produced once we started this program, the do's and the don'ts. of blood pressure, which also helps our patients when they come back into our clinic to realize when it's not being done right. So again, that self-management has just been really important. We've got feedback from our MA team that patients have said, I need to be quiet, or I can't talk, or I need to be left alone for that 5 minutes. So just teaching the patient we've seen some successes with that. On the back of this sheet here, you can see we have the patient's current blood pressure, the medications they're on, and follow-up appointments. So with the training, just access to the home blood pressure monitoring, I started off with our MAs and our providers. We have a folder that has all the information that's needed to give to that patient. We have a PowerPoint presentation that we give those patients, and then other literature that goes along with that. We also have the 24-hour blood pressure monitoring program in place as well, and that's done with one of our provider champions that I work alongside with. And he does the training on that, and he sets it up with the providers independently. So home blood pressure monitoring procedure. So a patient is identified for home monitoring by their PCP. Unless I implement the quarterly calls that we implement. Again, I am one person, so I don't get to all those calls on a quarterly basis. So we are reviewing, getting me an assistant to help out with those calls. The patient will meet with me once they're identified, and I'll sit down with them, they'll come in, and then we'll go through the PowerPoint, we go through lifestyle changes that need to be made with their medications, clear up any areas that they don't understand how their medications work. They show them how to use the home blood pressure monitor. This is one of the ones that we currently use that's in the little casing. Each casing has a little tag on it with the number on the monitor. And then we have the patient sign for the equipment responsibility if they damage it outside of normal damage. But these are the ones we currently use. And we also use a Welsh Allen home monitoring system as well that connects to the patient's phone. And the doctor can go and log into that to Welsh Allen, and they can look at their readings right there and then. And then the patient will be sent home with that blood pressure monitor. Most of them are sent home with them for 2 weeks, but again, that can be decided with their PCP and how they want to move forward and how long they want them to have it for. And then the patient will return for follow-up with the PCP. And then I'm a part of the provider team, so they keep me on board as long as they need me on board. We walk through with that patient until they have the successes that they're desiring. So it's definitely a team effort. Outcomes, the white coat syndrome eliminated. Constant observation and diary helps determine patient's needs. Patient medication regimen, we will increase the current dosage, additional medication added, or the current medication regimen is appropriate. So it just eliminates some of those guessing moments that doctors possibly have in that short amount of time that they get to spend with their patients. And then just the team approach is positive patient outcomes. Program maintenance, again, that having a champion is absolutely needed just keep everything moving. And then continuous feedback and reminders to staff regarding the home blood pressure monitoring services. This is really big. I found in our clinic is just there's so much that's being asked of our MAs, of our providers, and as you know, the medical field's constantly changing. So just that constant feedback and reminder, I'm kind of that little nagging person in the background. So it's really helped people, our staff will always come up and share with me that they've given out a monitor or they've set up appointments. And so it's just those gentle reminders throughout, and that consistency overall has been hugely beneficial. So I do that through emails. I attend staff meetings, and I continue to go over the different programs that I've implemented in our clinic. And then I do one-on-one with new staff members when they come on board. And then again, patient outreach via our EMR, and then quality reports pulled. Lessons learned, again the champion, consistency, training. A budget is needed to implement the program because of my time, and then possibly bringing on an assistant. And then just hypertension control rates did change when we initially started this program back in 2014 when I first came on, when we started with 1 million hearts. It was about a year into that we implemented the home blood pressure program, and providers did see changes and they feel like it's very beneficial. And then just more accurate treatment, just as Dr. Stoltz was saying, just that need for home blood pressure monitoring is so vital to the big picture of the patient. And then providers' feedback is just see the benefits of that team approach through patient education and their role in self-management practices. Getting the patient on board is key. The patient's got to want it more than we want it for them. So, yeah.
Bram Stoker is the guy that wrote Dracula. Yeah, that's the person that wrote Dracula. You say that? Is that right?
Good quote.
Thank you, Jamie. That was great.
Well, we knew this would be a packed hour with just lots and lots of great information and things to think about and things to implement. And we have about 4 minutes left for questions. So please chat some in or come off of mute. I'll pause for a second if you want to come off of mute and ask a question.
We did have one in the chat that came up earlier about blood pressure monitors at clinics. Who paid for those monitors, and were the monitors robotic?
Robotic. Yes, they were automatic cuffs that were purchased, and one of our grants that we received, we used for the purchase of those blood pressure cuffs, and then from now on, that's going to be the maintenance of those, and replacement will be something that the clinics will be purchasing and upkeeping.
And for those participants in Utah, Kelly Robinson from the State Department of Health, who runs the Million Hearts Coalition, was looking, they assisted with the grant, and they're currently looking for resources for SMBP monitors, and gave her contact information in the chat for those of you in Utah. Unfortunately, she didn't have any information if there's anything like that in other states, but to contact each state's Department of Health.
Thank you, Edie. Anyone have a question? You have questions for each other? Yeah, you've had some great successes, and we would love to continue this conversation next month in January. And actually, I'll just advance here to so you can see the date of our next webinar on January 24th. And if there's something you want to hear more about, please chat that in or let us know. But we want to know what you're doing in your setting. We want to know if you're implementing some home blood pressure monitoring programs. We want to know what your barriers are, what your success is, because there's a wealth of knowledge on this call today. I'm sure that various people on the call have done similar things, and you all have things to share with each other. So we want to check in January and see what you've had a chance to do and kind of problem solve and troubleshoot with each other, and hear what you think about the new guidelines and what your clinic thinks. Have you guys had that conversation at your clinics yet about the new guidelines? And
We have.
And what did you decide?
Our family medicine doctors are on the fence and kind of taking the same role as the AAFP at this point. So.
Yes, yeah, kind of a watch and see.
Yeah.
I think that's the approach a lot of people are taking right now, is kind of wait and see. But thank you for joining us today. The information was incredible. I think participants gained a lot from it. If you have questions and you're on the line and you want to chat those in, please do. We'll keep the webinar open for a few more minutes so that you can chat some questions in. We'll gather those up and see if our presenters can address them either offline or on the webinar next month. Again, like I said, Wednesday, January 24th is when we'll be doing that again. There is a post-webinar survey that we will ask you to complete, and the link to that is in the chat, so it's easily accessible for you there. And thank you for joining. Have a nice holiday season, everybody.
I think it'll be interesting to see what questions come in